By 2050, worldwide prevalence of myopia will be projected to be around 54%, and prevalence of high myopia will be projected to increase to 10%. As you all know, high myopia is associated with increased prevalence of eye conditions like leading to visual impairment. Younger children are more prone to greater annual progression and likely to achieve higher levels of myopia. Therefore, to ensure maximum benefits, early intervention is critical. Single vision spectacles, it has been confirmed that no effect has been seen in controlling myopia progression because the macula is in focus but the peripheral retina is blurry in case of single vision spectacles, leading to peripheral hyperopic defocus, which is the main cause, which is thought to be cause myopia progression. Also, it has been seen that under correction makes no difference compared to full correction, which even make myopia progression worse. Single vision lenses also do not protect against myopia progression, so that has led to the development of special type of spectacle lenses. Okay. So this is the schematic diagram of showing that correcting peripheral defocus. This blue line shows the image shell of the traditional correction, creating peripheral defocus. So ideal correction should be this orange line. The peripheral image also should be focused on the retina to retard the myopia progression. Coming to the bifocal spectacles. Executive bifocal spectacles with plus 1.5 diopter addition. Mechanism is it reduces hyperopic defocus in superior retina, thus reducing the accommodative demand at near. It has slowed rate of progression by 39 to 51% and axial elongation by 34% over 3-year period. It has been seen in Canadian Chinese children by Cheng et al. Also, it has been seen that inclusion of 3 prism diopter of basin prism had an effect in myopia progression in children with low accommodative lag only. Coming to the advantages, it has an excellent visual acuity at both distance and near, improved myopia control over progressive addition lenses. It is suitable for very wide range of prescriptions, no increased risk of microbial keratitis, good for those with dry eyes and allergies, and help control esophoria better. Disadvantages, near segment is cosmetically concerning and limit field of view and cause trouble when playing sports. Duration, even with low levels of myopia, full-time wear is suggested for both distance and near. Minimum frame size should be around 45 to 55 mm, with frame depth should be as large as possible, as it will maximize the treatment effect provided by near addition. Bifocal segment height should be set at 2 mm above lower limbus, which increases the likelihood of using near segment for near vision, this increasing the treatment effect. Review should be at 6 monthly first with annual cycloplasia, and if with 2 years of stable myopia, then it can be yearly. How to prescribe the spectacles? Executive bifocals are always at the top of the ladder based on the strength of myopia control efficacy, but still in terms of myopia, there are a number of factors to consider, like if executive bifocals are not liked by child or their parents, then we have to consider some other of the strategies. Indication, it can be any child with myopia, bifocal spectacles can be prescribed. Even if a child is on contact lens or any other pharmacological strategy, he or she needs a pair of spectacles lenses. And in those situations, why would not suggest a myopia control spectacle lens rather than a single vision spectacle lens? There is no particular contraindication to spectacle lenses. Some children are not inclined to wear glasses, like those interested in sports, active lifestyle, or those who dislike glasses due to cosmetic aspects. If progression remains stable for 2 years or more, then we can consider discontinuing bifocal spectacle lenses and revert to single vision contact lenses or spectacle lenses or contact lenses. Now coming to multifocal contact lenses, it comes in range of designs like center distance, bifocals, simultaneous defocus, and extended depth of focus. Center distance bifocal lenses, central portion corrects the nearsightedness, that focuses light directly on the macula, and the outer portion adds focusing power, which brings peripheral light rays into focus in front of the retina. And it has been shown that it reduces myopia progression by 25 to 72%. Simultaneous defocus contact lenses have alternating rings of treatment plus power and correction zones. It provides image that is simultaneously focused on the retina, in front of retina, inducing again myopic defocus, and it reduces myopia progression by 36 to 59%. EDOF myopia management lenses utilize selective manipulation of higher order aberrations, achieve extended depth of focus, facilitating visual performance across all distances, far to near. Coming to the advantages, it has a wider field of view, excellence, cosmesis, and sports, control treatment, as therapeutic effect is applied in all positions of gaze. Treatment zones don't vary with eye movements, and better when large degree of anisometropia is present. However, it has lower quality of vision compared to spectacle lenses. Small risk of microbial keratitis around 4.42% and not suitable for those with dry eyes. We have to consider multiple things when prescribing a child with a multifocal cornea, and it has to be always discussed with the child as well as the parents. Child's interest and motivation to wear contact lenses, maturity level, we have to see the personal hygiene habits, ability to take care of contact lenses by him or herself, participation in sports. The normal design and add of multifocal soft contact lenses, which are commonly prescribed, is center distance multifocal lens designs, and generally up to plus 2.5 diopter is the maximum addition, as it gives more add interface with distance visual acuity. Multifocal contact lenses prescribing, it can be used as long as possible, 7 days a week. Review first initially 1 week to check for fitting, comfort, and then 1 monthly, 3 monthly, and if progression is slowing, 6 monthly. And once progression stops, we can consider stop contact lens use in the early 20s.